Good day. My name is Dr. Ahmed Abusab, and I'm going to talk today about dental implant osseointegration. Professor Brannemark defined osseointegration as a direct structural and functional connection between living bone and the surface of a load-carrying dental implant. By simplifying this definition, we can say osseointegration means direct contact between the bone and the implant interface, as shown in this figure. So it's very important for every clinician to know the phases of implant osseointegration. So immediately after the implant is inserted into the jawbone, the peri-implant bone passes step by step through different phases of histological change to reach the final change of osseointegration of dental implant with the surrounding bone. Any clinician should be aware of these histological change, as all these can be deciding factors in the modification of the conventional two-stage implant treatment protocol to one-stage immediate or early loading of the dental implant. So as we see in this figure, we have three phases: the inflammatory phase, the proliferative phase, and the maturation phase. Two terms, we have to know the meaning of each term: contact and distant osteogenesis. So after the implant insertion, new bone formation begins simultaneously at the prepared osteotomy wall and the implant surface. The new bone synthesis, which begins at the implant interface, is called contact osteogenesis, and other synthesis, which simultaneously begins at the osteotomy wall, is called distant osteogenesis. Completion of both osteogenesis process results in complete new bone synthesis at the implant bone interface, which is finally called implant osseointegration with the jawbone. As we see in these two figures, on the implant interface, we see the contact osteogenesis, and on the bone interface, we see the distant osteogenesis. It is also very important to know about the primary and the secondary stability. What we see in this figure is the primary and secondary stability curve of the implant during the transition period. So osseointegration requires bone apposition on the implant surface without any micro movement. During implant insertion, the stability that the implant achieves is completely mechanical and is called the primary stability of the dental implant. And during the healing period, the biological process of osseointegration changes to a mixture of mechanical and biological stability, which means that the mechanical stability decrease and the biological support start to increase. Further, during the biological process of osseointegration of the implant, the bone physiologically changes during the multiple phases of bone resorption and new bone formation over the implant surface, and any micro movement of the implant during this phase may lead to failure of implant osseointegration. So as we see here, we have three phases: the early phase, transitional phase, and the late phase. In the early phase, we have high primary stability, mechanical, which we gain during the implant insertion, and minimal biological support. And as we go to the transitional phase, the old bone is being resorbed, and new bone is not fully forming. And this is the most risky period for implant placement. Any micro movement that may happen at this period will lead to osseointegration failure. And the late phase, where the secondary biological stability increase and the overall stability increase. Soft tissue integration around implant superstructures like the transmucosal healing abutment, the final abutment, can be defined as biological process that occur during the formation and maturation of the structural relationship between the soft tissue and the transmucosal implant superstructure. So we must know that the soft tissue integration around dental implant is equally as important as osseointegration for long-term success of implant-supported prosthesis. So if we have an area which is devoid of attached and keratinized soft tissue grafting procedure should be performed to regenerate a healthy, thick, attached keratinized zone of marginal soft tissue, minimum 2 to 3 millimeters around the implant superstructure. The natural tooth possess periodontal ligament space, which not only provides additional nutrient supply to the periodontal hard and soft tissue for their maintenance and long-term survival, but also acts as a shock absorber against undue forces over the tooth, which is not the same situation on the dental implants. Because the implants, which gets direct osseointegration with the bone, shows no structure like the periodontal ligaments, and only possess limited source of nutrient supply to the peri-implant tissue, and also transfers all the occlusal force directly to the bone. So as we see in this figure, on the left side, we have the attachment to the tooth and the blood supply. Here we see the blood supply and the blood supply on the right side. Much less blood supply to the implant. So the peri-implant tissue, both as well as soft tissue, receive blood supply from only two sources, from the periosteum and from the basal bone. They don't have the third source of blood supply like the natural tooth, which is the periodontal ligament. Thus, the peri-implant tissue with limited thickness may find it difficult to survive and may get resorbed due to deficiency in blood supply. The peri-implant soft tissue doesn't show any connective tissue attachments to the implant core and its superstructure like the natural tooth. And thus any physical or chemical injury to the soft tissue sulcus may directly affect the peri-implant crystal bone and may cause crystal bone resorption. For this reason, sulcular probing around the implant is not recommended. Thank you for listening. Follow and contact me on this QR code. Thank you.